So the Socratic battle, the debate, thank you. It'll be so easy. I didn't even prepare slides. I just figured, that's going to be automatic. So thanks, Joel, for coming to New York. And let's talk a little bit about endoscopy. It's very complicated. If you look at all the names for endoscopy, like a million names, all for the same procedure pretty much, that already should make you suspicious somehow, right? Look at the role of MIS currently. If you look at the complexity of surgery at the bottom, it gets more complex towards the right, and then invasiveness. Now, with traditional open surgery, it gets pretty invasive pretty early on. Now, with MIS, the whole point is to dampen the curve, right? So, and then the benefit zone is really in between. Benefit zone, in my opinion, is multi-level decompression surgery, maybe at 1, 2, 3 level fusion. Patients with that require up to a 3, 4 level fusion. I think beyond that, it's not really that important. It's just too complex. It gets too complicated. So the benefit zone for MIS is kind of like this mid portion between degrees of complexity. And but that you got to keep in mind that about 75% of all spine surgery, though, falls into that segment, right? So I think it is important to learn about tubular surgery. But what about endoscopy? We have all these enabling technologies, and we saw today beautifully that navigation, robotic surgery, AR, VR, it's penetrating really the whole spectrum of spine surgery from A to Z. Microscopes, tubes, huge application. Expandable technology, very, very exciting. And where's endoscopy? It's like all the way on. It's basically, it's not even the benefit zone for MIS, right? It's kind of like the learning curve for MIS. And that's where endoscopy is really relevant right now. And I hope, you can convince me otherwise, Joel, but it is just very, very limited. And in terms of the tubular approach, I'll try to show you some of the benefits of tubular surgery over endoscopy. And also that a lot of the things, or pretty much everything you can do with the endoscope, you can really do with the tube. There's no reason to think that the endoscope really allows you to do certain things that we just can't do with open surgery or with tubular surgery. Why has endoscopy not really taken off? Obviously, technical limitations, and we heard that earlier. Some of the surgeons said, well, we're just not there yet. And every time I show them a case, are you going to do that with the endoscope? There's always another excuse. There's always not the right case, it's not the right level, it's too big, it's too small. This has been around for decades. You would think that somebody has overcome these technical challenges. So let's go through some of the literature in terms of learning curve. Most places and most surgeons that you talk to the learning curve is much, much more difficult. And after all these years, I understand every technology has ups and downs, but after all these years, all we've gotten to is really endoscopic microdiscectomies. That's the only procedure in the endoscopy world that's really accepted. Now let's talk about operative time. And most studies that compare tubular to endoscopic surgery show that operative time is actually significantly longer with endoscopic surgery. And this is a study comparing tubular discectomy to endoscopic discectomy. So significantly longer. Sorry, Joel. So let's look a little bit more at other endoscopic procedures. So tubular is 27 minutes faster than biportal endoscopy. In those 20 minutes, take a medical timeout and relax in my office. Let's talk about complications. And complications, we're looking at dural tears, neurological defects, wound infection, and others. Also here, the literature, this is a meta-analysis, favors tubular surgery over endoscopic surgery. A recent meeting, these were the issues that were discussed at a recent big spine meeting. Learning curve is substantial. The cost of instrumentation is significant. Radiation exposure with endoscopic surgery. It should be remembered that conventional microdiscectomy may be the more favorable option in some cases. So this is all worrisome. But I think with direct visualization, that's better. You can probably avoid a lot of those injuries. Hematomas. Hematomas after surgery, endoscopic significantly more than conventional MIS procedures. So these are all data in the literature. Costs, of course. Endoscopy, significantly more costly. Now, we're just introducing an endoscopy system in Tanzania, and it's almost impossible because the infrastructure is not there. And this is really, really difficult versus tubular surgery. This was in Mexico a number of years ago. I was visiting an operating room. They take the syringes, they cut them off. This is really cheap, easy, simple, safe surgery. Of course, then you need a microscope, but you can overall, the safety record and the success record of tubular surgery is proven and is really documented and is, I think, much more versatile than endoscopic surgeries. It's a surgery that is being done with a few instruments. It's very straightforward. You need some tubes. Obviously, you can use a microscope or the endoscope. I'll show you some other options. We wrote it up, the 10-step technique for MI's tubular over-the-top laminectomy. Somebody mentioned earlier they're worried or they're afraid of the dura on the other side when they do the over-the-top decompression. Well, I mean, there are ways around that. You got to drill. This is really manly surgery. Tubular surgery is for the real man. Endoscopic surgery, I don't know. I don't get this there. But for the over-the-top decompression, you got to drill behind the ligament on the other side. And then you can very, very safely remove the ligament and really decompress the contralateral aspect of the nerve roots even better than the ipsilateral, right? And the endoscope, of course, you can do that, but it takes forever. And there are still concerns, as we can hear from some of the endoscopic surgeons. When I thought about endoscopy, I thought there were two indications potentially. It's like the extraforaminal, transforaminal approach, and then thoracic disc herniations. And I want to say a few words about both of those. This is a patient who had foraminal pathology here with disc ossified complex with significant weakness in his foot. And he didn't want a fusion. He asked me to do an extraforaminal decompression. This is Ralph Wagner's slide that very beautifully shows the foraminal pathology. That is for an endoscopy chapter in our book. But you can treat this through a tubular retractor, a 15-millimeter tubular retractor. I use navigation to plan the skin incision. I bring in the microscope. We tilt the table away. You have a beautiful trajectory into the foramen and can take care of all of these foraminal pathologies very safely. You can see the nerve root in 3D. You can protect the nerve root and very effectively then decompress the exiting nerve root. Now, the question is, well, how far can you reach into the spinal canal? And I agree that with the tube, you may not be able to reach very, very far. But here on this slide, you can see that we can definitely get into the spinal canal and you can see the dura. You may not be able to go as deep as with the endoscope maybe, but with a tubular retractor, if you open up the frame, you can really get in there. L5, S1 is not an issue. I know with the endoscope, there are concerns about L5 and S1. With the tube, you can always get into the foramen from the outside and very nicely decompress that. This is a case that we did over the top. This patient has lumbar stenosis and a foraminal disc herniation right in the foramen on the right side. We wanted to treat both. And again, this was done with navigation over the top. So we came from the left side and then with a tubular approach, did a laminotomy, went over the top, went all the way down into the foramen and cleaned out the foramen on the contralateral side. Very nicely done. That patient went home the same day. And I think it's a great example where tubular surgery is certainly not inferior to some of the other things that we do with the endoscope. But we have a million different names, and this was recently, one of your assistants sent me that over, Joel, where that patient was asking, what are these approaches called? And you were very kind to walk that patient through the number of different approaches. And the patient became a little bit irritated. It's too complicated. I'm going to just... So thank you. Thank you so much.
Okay, I would like to say a couple of things for posterity. The first is that great tubular surgery still is far better than mediocre endoscopic surgery. And the second thing I want to say for posterity is that even though this is supposed to be a battle, I'm more of a lover than a fighter, so you're going to see a very different talk. I call this procedure LESS, lumbar endoscopic spine surgery, and you have to admit that is a very cool name for a minimally invasive procedure. Much better than tubular microdiscectomy, so I'll just say that. If you just type into PubMed, lumbar endoscopic discectomy, you get a fair number of publications. That's a lot. And if you compare it to microdiscectomy, it's more, but more importantly, it's equivalent. It's not one of these procedures that we've not looked at. In fact, we've looked at it a lot. And I'll give you an example. If you just look at the literature that directly compares microdiscectomy and endoscopic discectomy. Starting way back in 2016, there's this randomized controlled trial. Then in 2018, there is a systematic review and meta-analysis. And then after that, there's another meta-analysis. And then after that, there's a large prospective comparison. And then after that, there's yet another comparative study through the Spine Tangle Registry. And I could just keep going on and on, but I just got tired after a while There's so much data, and check this out. I thought, I wonder what ChatGPT has to say about this. Because think about it, AI is only as intelligent as the information that we give it. So it's going to give an answer that's good if there's enough information in there. Just imagine like a person that is looking to have surgery, and it's me, and I say, pretend I'm an active professional who loves playing golf, working as a surgeon, and traveling, who has severe pain from a lumbar disc herniation. Should have a tubular microdiscectomy or an endoscopic discectomy. That answer is pretty dang good. Of course, every procedure has a pro and a con. The cons are a larger incision compared to endoscopic approach, a longer recovery time, and the potential for muscle disruption around the spine. By the way, I'm a big believer in the multifidus muscle as the dynamic stabilizer of the spine. And if you believe that the multifidus muscle is important, generally don't want to cut that tendon if you can avoid it. So I think that's a big deal, despite the fact that this is a great operation. Now, what does it say about endoscopic surgery? Smaller incision, less tissue damage and scarring, shorter recovery, reduced postoperative pain, and faster return to activities like golf or travel. Cons are limited visualization and access, not ideal for all types of herniations, requires a skilled surgeon, experience in endoscopic techniques, and a slightly higher risk of incomplete removal in certain cases. Dang! That is a very, very good synopsis of what I think the difference between tubular microdiscectomy and endoscopic discectomy is. Because in reality, every patient's different, and I'm the type of person that has multiple guns. It kind of depends on the battle that I'm about to fight. So I think we've been saying it. If you want to be an excellent minimally invasive and endoscopic surgeon, I still think you still need to be a very good mini-open and open surgeon. It's not a mutually exclusive thing. It's just an added piece of equipment that you can employ at the right circumstances. So that's rock solid information, and I can't do any better than that when I talk to patients, because I still offer them both and give them both. So the question of does endoscopy work, and is it a viable thing, and is it better than microdiscectomy? Well, it's separate from is it better. It works. That's not the question. The real question is, if it's so great, why this poor adoption? And I think there's two major reasons. The first is reimbursement. Let's not talk about that. The second thing that's been alluded to already, the learning curve is very, 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 and did I mention, very difficult? Like back in 2014, that's like 10 years ago, I did a systematic review. And essentially, the learning curve is 35 to 72 cases. That is way too many for a reasonable adoption, the way most new things are adopted. So it should be that most new technologies are adopted in the teaching program, and you have 5 to 7 years to learn it. But it tends to occur in the community with attending physicians, and only when it starts to be viable, then the academic institutions do the randomized controlled trial. And there's been a recent one from this very institution, November of 2023. That's not that long ago. 31 cases, so clearly the learning curve is probably one of the most significant obstacles to adoption, because you know what's interesting? I hardly ever see after these learning curve studies that they just describe it. It's like it takes 32 cases and it's this complication rate. And really, we should be asking why, but even more importantly, we should be asking how can it be improved? So let me just end with a patient example, because in the end, we're here to take care of our patients in the best way possible, while at the same time having a practice that you enjoy doing. So here's a guy. He is a 49-year-old attorney, got severe back and right leg pain, a partial foot drop. He's an avid surfer, cannot surf, and he's a lawyer, so he sits a lot and travels. And you can see he's got a pretty big disc herniation. Now, here's what's interesting. A few years before, he had a 4 or 5 disc herniation, treated with a microdiscectomy by a local colleague who are very good surgeons. So I hope you're wondering right now, a patient that's had a microdiscectomy once and then has had an endoscopic discectomy thereafter, I wonder what they're going to say. He texts me, post-op day 2, I think. I'm very thankful. I told my lawyer friends that maybe you wouldn't want me to share my experience because it has been too good. If anyone would have told me I would feel this way 2 days out, I would have called BS. Sorry to bother you on a weekend. I just know that good news from my clients makes my day always, and I hope you have a great vacation. And guess what? That made my day. So with that, thank you, Roger, Luis. These are 2 of my mentors, heroes, and I really was scared, but I hope you have some insight as to kind of what I think about endoscopic surgery, the respect that I have for great surgeons and a great microdiscectomy. So thank you.